Welcome to the Cytokine Signaling Forum's highlights from ACR 2021, where authors take us through their posters and presentations on cytokine signaling and JAK inhibitors. My name is Len Calabrese. I'm the head of the Cleveland Clinic's section of clinical immunology. You know, patient-reported outcomes are incredibly important. They have links to patient satisfaction and adherence. ACR 2021 had some really fascinating presentations on PROs from pain to fatigue, which are so important to patients. And now we're going to take a look at them.
Hi, my name is Louis Bessette. I'm a rheumatologist in Quebec City, an associate professor at Laval University. And it's a real pleasure to present you the result of our project, the impact of early pain improvement on patient-reported outcomes in patients with psoriatic arthritis. It's a result of the phase 3 studies. So why doing that analysis? As rheumatologists, we know that pain is a dominant feature of PSA and other rheumatic diseases also. Joint pain affects a lot of our patient in terms of quality of life. It has an impact on fatigue, it has an impact on work productivity, it has an impact on function. So I think it's very important to understand what it's mean for the patient in terms of pain improvement and the impact of their quality of life in our clinic. So to do this analysis, we use the data from the phase 3 SELECT PSA-1 study. SELECT PSA-1 study was a study that evaluated the efficacy of 2 doses of upadacitinib, 15 milligrams once daily and 30 milligrams once daily against placebo. PSA-1 also had an active arm, adalimumab 40 milligrams every other week. For this analysis, we took the patient who had at baseline, a patient global assessment of pain on numeric rating scale of at least 2, so a score of 2. And we defined pain improvement by achieving a score of less than 4 on this numeric rating scale and an improvement of at least 2 points from baseline. So the first analysis we did is to look at the proportion of patients in each treatment arm achieving meaningful pain improvement through week 24, as I defined before, what the meaningful pain improvement mean for this analysis. Second, we look also at among those achieving meaningful pain improvement at week 4 in each treatment arm, what was the proportion of patients achieving it at week 24, so they maintain their pain improvement between week 4 and 24. And lastly, but not the least, we were very interested among those patients who achieve what we define meaningful pain improvement at week 4 and at week 24, what was a proportion of patients reporting at least a minimum clinically important difference at week 24 on different patient-reported outcomes, such as HAQ-DI, the fatigue measured with the FACIT scale, the SF-36 physical and mental component summary scale, recall 5D, work productivity and activity impairment. So these are the main description of our methodology. So what we did find actually, so for the first analysis, what we found is that a significantly greater proportion of patients had meaningful pain improvement with UPA, both doses, 15 and 30 milligram, and adalimumab compared to placebo. And we saw the difference starting at week 2, as you can see on figure 1 on the poster. We also found that compared with adalimumab, a significantly greater proportion of patients achieved meaningful pain improvement with UPA 15 milligram, and that difference was seen at week 20, and also for UPA 30 milligram, and that difference was seen at week 4. Second analysis, as I mentioned, was to look at the proportion of patients who maintain week 4 improvement at week 24. And the proportion of patients who obtained that, meaningful pain improvement at week 4 and maintained that meaningful pain improvement at week 24 was between 82 and 87%, with no major difference between a different group. And for the last analysis, as I mentioned, we wanted to look at the impact of a meaningful pain improvement on patient-related outcome at week 24. So for those patients who attain meaningful pain improvement at week 24, and this is presented in figure 3, a significantly greater proportion of patients reported value at least of the MCID for all reported patient outcomes at week 24. So as an example, for fatigue is a very important part of, outcome in our patients, very important for patients to improve fatigue over time. So for those who achieve this meaningful pain improvement at week 24, 72% of these patients had at least a minimally clinically important difference at week 24 on the FACIT scale, compared to 44% of patients who did not achieve that meaningful pain improvement. It was the same for all the other outcomes at the high, 70% compared to 34%. And this is presented in figure 4. We also look at those patients who pain improvement, meaningful pain improvement occur at week 4. What was the impact on MCID for patient-reported outcome? And we found very, very similar data. So in conclusion, what we can see is that, there's a greater proportion of patients achieving meaningful pain improvement with UPA and ADA versus placebo, and that difference was seen at week 2, so very early pain improvement. There were also meaningful pain improvement by week 4 and week 24, and that pain improvement was associated with more patients reporting improvement of at least the MCID on different health-related quality of life and PROs at week 24. And overall, meaningful early improvement, so one patient improved very early in PSA, is closely linked with clinically relevant improvement in other outcomes, as I mentioned, health-related quality of life and physical function. So I think these results are very important because in rheumatology, patients come in our clinic because they have pain. They don't really care about swollen joint. They really have pain, impact on function, fatigue, and it has an impact on every aspect of their life. So what they want really is the rapid improvement of pain. And this is what we can achieve with these medications. And by achieving a meaningful pain improvement very early has a major impact on patient-reported outcome over time. So thank you for your attention.
Hi, this is Vibeke Strand, and I'm an adjunct clinical professor in the Division of Immunology and Rheumatology at Stanford. And I'm presenting poster number 741, assessing the relationship of patient global assessment of disease activity and health-related quality of life with other patient-reported outcomes in rheumatoid arthritis, post hoc analyses of data from phase 3 trials of baricitinib. And I want to include a thanks to my co-authors and particularly to Peter Taylor, who is going to be standing, quote unquote, by the poster during the virtual ACR. So what we know already and has been published is that baricitinib treatment results in statistically significant and clinically meaningful improvements in patient-reported outcomes versus placebo. And this includes patient populations that were methotrexate naive in RA Begin, CS-DMARD incomplete responders in RA Beam, and bio-DMARD IR patients in RA Beacon. So these analyses were designed to examine the relative importance of several PROs on patient global assessment of disease activity and health-related quality of life, looking at the SF-36 physical and mental component scores, PCS and MCS, and to assess whether there were differences between patients who achieved low disease activity or remission versus those who did not. And the PROs included patient global assessment, disease activity, pain, facet fatigue, morning stiffness, and HAQ disability index. So there were multiple regression analyses that were performed for the overall population, as well as those two subgroups that I mentioned to you, Those with CDAI scores of less than or equal to 2.8, therefore in remission. Those with CDAI scores that were less than or equal to 10 and therefore low disease activity, versus those without either remission or LDA. And this was at baseline in week 24. And standardized parameter estimates for each PRO are presented. Now, what we were looking at is correlations between these various patient-reported outcomes across the 3 randomized controlled trials. And we already know that pain is strongly correlated with patient global assessment of disease activity. And again, this is shown here with a correlation of 0.89 to 0.92, which is quite high. And from regression analyses, we also know that it is the most important influencing factor for patient global. Pain was also negatively correlated with SF36 PCS and MCS scores, more so with PCS minus 0.63 to minus 0.69, versus MCS about half of that, minus 0.32 to minus 0.34, so low correlations. Facet fatigue was moderately positively correlated with the PCS and MCS scores in range of 0.65 to 0.7. And again, it was the most important influencing factor across the regression analyses for SF36 mental component scores. Facet fatigue and patient global were moderately negatively correlated, which is interesting, but certainly indicates how important fatigue can be. The HAQ Disability Index was moderately positively correlated with patient global and was the most important influencing factor for PCS scores. It was also strongly negatively correlated with the PCS at correlations of minus 0.75 to minus 0.8, but weakly negatively correlated with MCS scores. And interestingly, duration of morning stiffness was weakly correlated with patient global and PCS scores, and even more weakly with MCS scores. And in part, this may be because we know morning stiffness tends not to change as rapidly, even in clinical trials. So what's interesting is when we looked at the regression analyses, according to patients categorized by CDAI responses, we saw similar results, whether they were in low disease or remission or non-responders. So thank you very much.
Hi, I'm Hannah Kim, an assistant clinical investigator and head of the Juvenile Myositis Pathogenesis and Therapeutics Unit at the National Institute of Arthritis and Musculoskeletal and Skin Diseases, or NIAMS, at the NIH in Maryland. At the 2021 ACR Convergence meeting, I presented poster number 0773 on behalf of my co-authors, entitled Janus Kinase or JAK Inhibition with Baricitinib, Dosing and Patient-Reported Outcomes in Refractory Juvenile Dermatomyositis, or JDM. To provide some background, JDM is a systemic autoimmune disease with a prominent interferon signature, which has been found to correlate with disease activity. Standard treatment is empiric with high-dose corticosteroids and other immunomodulatory agents, though most patients still have a polycyclic or chronic disease course. Janus kinase or JAK inhibitors can target the interferon signaling pathway, and Mendelian interferonopathies have been successfully treated with JAK inhibitors. We assess baricitinib, one of the JAK inhibitors, in active refractory JDM as part of a compassionate use program. We demonstrated efficacy by decreases in validated disease activity measures and proof of concept with decreased interferon markers by 24 weeks. This was published in Annals of Rheumatic Disease last year. Briefly to review the cohort and what was found by 24 weeks, these 4 JDM patients were between 5 and 20 years of age at enrollment and were still active despite trying 3 to 6 disease-modifying anti-rheumatic drugs and/or biologic agents. All 4 had refractory skin disease and 2 also had active muscle involvement. Improvement was noted in both skin and muscle disease by standard validated measures, which was supported by objective photography of rashes and MRI of muscles. Baricitinib was provided by Eli Lilly and Company, the sponsor of the Expanded Access Program. In this study, we focus on patient-reported outcomes and dosing with extended follow-up through 72 weeks. Regarding the methods, we collected 4 patient-reported outcomes. One was a daily symptom diary score we created with patients noting the impact of 4 symptom categories: rash, musculoskeletal pain, fatigue, and weakness on a scale from 0 or no impact to 4 or maximal impact. This was done daily. Daily scores were averaged between clinic visits. The other three measures were the Patient Global Activity by Visual Analog Scale, Childhood Health Assessment Questionnaire, or JAK, and the Childhood Health Questionnaire Physical Summary Score, or CHQ-PHS. These have all been established and validated as juvenile myositis core disease activity measures. Linear mixed models were used to compare measures to baseline. Safety and tolerability were assessed. Baricitinib dosing utilized previously published dosing and pharmacokinetics established in pediatric Mendelian interferonopathies based on weight and renal function, which includes an option to escalate doses. In the results, we graphed the outcomes for each patient at baseline and then at 4, 8, 12, 24, and 72 weeks. So that timeline is not linear. The mean daily symptom diary score decreases over time, reflecting significantly decreased symptoms. By week 72, there was a 68 to 83% decrease. The patient global activity was also significantly decreased, reflecting decreased disease activity. By week 72, there was a decrease from a mean of 5.9 out of 10 to a mean of 1.7 out of 10, with a 48 to 92% decrease. The JAK disability index scores decreased, indicating less disability, specifically decreasing from a mean of 1.13 to a mean of 0.66 out of 3. The CHQ-PHS for the 3 pediatric patients increased, indicating better physical function related quality of life. All 4 measures show notable improvement between week 24 and week 72. Regarding dosing, patients were started on 4 to 8 milligrams a day of baricitinib, divided BID or TID. By week 72, patients were on 5 to 12 milligrams a day divided BID, based on renal function, safety labs, and/or efficacy. There were no serious adverse events. Infections were the most common adverse event, and the most common infection was upper respiratory infection. No adverse events required holding or discontinuing baricitinib. In conclusion, refractory juvenile dermatomyositis patients on baricitinib had improved patient-reported outcomes with significantly less symptoms and disease activity reported. They also reported less disability and better physical function-related quality of life. For all of these patient-reported outcomes, there was continued improvement beyond 24 weeks or 6 months. Minor baricitinib dosing adjustments were made within previously established dosing for pediatric Mendelian interferonopathies. Baricitinib continued to be generally well tolerated with extended follow-up. Thank you for your attention.
So good morning, my name is Bruno Fautrel. I'm professor of rheumatology at Sorbonne University in Paris, and I'm very happy to present you a summary of the abstract we are presenting during the ACR 2021 meeting, a poster that we have done with my colleague Tsutomu Takeshi in Japan and all our colleagues from Lilly, since it was based on a post-hoc analysis of 2 randomized controlled trials conducted with baricitinib. So the title of the poster is Treatment Effect of Baricitinib on Fatigue, Mediation Analysis, Results from 2 phase 3 trials. So as you know, fatigue is always or very frequently a problem for physicians and for patients, of course, because we are used to adapt and to adjust our treatment based on disease activity. And even though the disease activity is well controlled, we have frequently patients complaining from remaining fatigue, and we are not completely comfortable with fatigue management, which can be linked to the disease, which can be linked to other phenomena. And here in this abstract, what we wanted is to probably understand more deeply the relation between disease activity and fatigue and the potential effect of baricitinib on this specific patient-reported outcome, as we did a few months and years ago about pain. So what we did, we used the data from 2 randomized controlled trials conducted with baricitinib. One trial was ARA-BEAM, randomized controlled trial conducted in ARA patients with an inadequate response to methotrexate, and patients were randomized in 3 arms. One was a placebo, one was baricitinib at the usual dosage of 4 milligrams per day, and one patient received adalimumab at 40 milligrams every other week. And the second trial was a slightly different population with ARA patient with an inadequate response to TNF blockers, so people who were more experienced with regard to ARA treatment. And these patients were randomized either on placebo or baricitinib 2 milligrams per day or baricitinib 4 milligrams per day. And to analyze the data, we use a specific statistical method, which name is Mediation Analysis. And the objective of this method was to identify an indirect impact or effect of the treatment on fatigue, which was the outcome of interest in this post-hoc analysis. An effect which goes indirectly from disease activity reduction, then fatigue improvement, or to identify a direct effect related to the compound on fatigue, irrespective of an impact on disease activity. So to assess disease activity, we use the CDI, and in the model, we included the CDI, which was dependent variable, which may impact fatigue, and two independent variables which corresponded to the treatment, baricitinib or adalimumab, for the study, the ARA-BEAM study. So the main result of the poster of this study was that the profile is approximately the same between the two diseases, with one part of the impact of treatment of baricitinib on fatigue, which is related to disease activity improvement. And for example, in the ARA-BEAM study, between 50 and 70% of this change in fatigue was related to an improvement or reduction in CDI, in disease activity. But it means that between 30 and 50% of the impact of baricitinib on fatigue was not related to disease activity and was linked to a direct effect on fatigue of baricitinib, which is a very interesting finding. And when we compare this with adalimumab in the ARA-BEAM study, we saw that the impact of adalimumab on fatigue was less important. And we also saw that the direct effect of adalimumab on fatigue was lower, let's say, between 20 and 30% of the impact of adalimumab directly on fatigue and not via disease activity improvement. And this study has been confirmed with the ARA-BEACON population, so the population which was already experienced with biologic DMARD and who had an inadequate response to a previous biologic DMARD. And there, it was only patients treated with baricitinib, when we see exactly the same with a significant impact, direct impact of baricitinib on fatigue. So this post-hoc analysis is very important for us to understand in what extent we may act on fatigue. And of course, the improvement in disease activity and the reduction in disease activity thanks to any DMARD, either biological DMARD or targeted synthetic DMARD such as JAK inhibitor, it may be observed thanks to the effect of the drug on disease activity. But there is a signal and a trend to say that with baricitinib, there is a direct effect on fatigue, and we had exactly the same picture as the one we had a few months or a year ago about pain, which is that maybe with JAK inhibitor and specifically with baricitinib, we have a direct impact on pain and on fatigue. So it doesn't mean that we can control all this phenomenon, fatigue, with only the action of baricitinib, but it shows that there are differences between the different DMARDs that we may use. And among all these DMARDs, baricitinib are probably one of those with the highest impact directly on fatigue and, of course, on pain, as we saw in previous meeting. So I would thank you for your attention, and we hope to see you during the live session of the ACR meeting.
Good morning, dear colleagues. I very appreciate that you invite me to such interesting meeting. And my name is Elena Pogozheva, and I'm rheumatologist from the Nasonova Research Institute of Rheumatology in Moscow. I'd like to introduce my report, tofacitinib in rheumatoid arthritis. Is there a correlation between a rapid analgesic effect and decrease in activity after 3 months and 6 months of therapy? So a little about background. So we know that the main manifestation of rheumatoid arthritis are the inflammatory destructive arthritis, chronic pain, fatigue, functional disorders, anxiety, and depression, which are part of the patient-reported outcomes. These manifestations of the disease cause the greatest suffering, a decrease in the quality of life and social activity of patients. Therefore, a positive impact on the PROS is today the most important aspect of evaluation of results of ERA therapy. We know the two main ways that the immune inflammation can influence the pain. First of all, it's a peripheral sensitization due to local inflammation, due to systemic increase in cytokine levels. And the second way is a notoplastic process. And the signs of central sensitization that the cytokines effects on the nervous and glial cells and detect the transmission in neural system. And of course, due to psychological distress and some effects of central nervous system cause on inflammation. The high analgesic effect of tofacitinib, the first drug in this place, a predominantly JAK1/3 inhibitor, is determined by its ability to block the JAK-STAT signaling pathway and suppress cytokine-mediated expression of genes responsible for the systemic of inflammatory and pain mediators. JAK-STAT block prevents the development of a central sensitization, then the nervous system becomes more sensitive to pain. So we know that tofacitinib has been associated with rapid, sustained pain reduction in patients with inflammatory rheumatic diseases. This post-hoc analysis used data from the following double-blind placebo-controlled trials, which evaluated the impact of tofacitinib on patients' reported pain. It's 7 RCT of patients with rheumatoid arthritis, psoriatic arthritis, and 1 about ankylosing spondylitis. And this study showed that the marked pain reduction occurs already in the first month of the disease. But the relationship between the rapid pain reduction and activity of the disease as a long observation period is not well known. So the aim of our study was to assess the relationship between the earlier clinical response to tofacitinib and the decrease in rheumatoid arthritis activity after 3 and 6 months. Our study was a part of the great national register of patients with rheumatoid arthritis who had an adequate response to DMARDs and who received tofacitinib. You can see that I have so much collaborators, and thank you so much all of them for its hard work. You can see that it's 20 medical centers in 16 main towns all around Russian Federation. So the study group consists of 88 ERA patients. It's an open observational study. The mean age was 53, and up to 80% of patients were women, and the main disease duration was 5 years. And the most of the patients were positive by RF and have had the high disease activity by index DAS-CRP. Most of the patients received methotrexate and 18% leflunomide, and all of the patients received tofacitinib 10 milligrams per day. The severity of pain was assessed using the brief pain inventory questionnaire, signs of central sensitization using the central sensitization inventory questionnaire, and reactivity, as you know, as a index DAS-CRP. The follow-up period was 1 week, 2 weeks, 1 month, 3 months, and 6 months of follow-up. So about the results. After 3 and 6 months of therapy, there was a significantly statistically decrease in disease activity according to the CRP index in comparison with baseline level. There was a statistically significant difference because this CRP after 3 and 6 months. Low reactivity after 3 months was achieved in 64% of patients. According to our data, the use of JAK inhibitors in ERA allows for rapid clinical improvement. As you see, after 7 days, the intensity of pain decreased by more than 20%, and after 28 days, the number of patients with a decrease in pain intensity, more than 50% from the baseline level, was almost 60%. So the pain reduction was accompanied by positive dynamics of parameters of physical and social activity of patients assessed by the BPI questionnaire. So as an important result of our work was the confirmation of the influence of tofacitinib on central sensitization, assessed using CSI questionnaire. During treatment, there was a pronounced and statistically significant dynamics of this indicator. This can be considered as a confirmation of the specific effect of JAK inhibitors on the development of chronic pain. So there was a strong correlation between the number of patients with significant pain reduction after 28 days and the number of patients who achieved a low ERA activity after 3 and 6 months. So the main results of our study confirm that there is a concordance between a rapid pain decrease and inflammatory activity of the disease in a long period of observation. So our conclusions, you can see in a slide, which show the statistically significant correlation between an early good response to tofacitinib, pain reduction by 50% or more after 28 days, and the achievement of low ERA activity after 3 and 6 months of therapy. These results clarify the relationship between pain and immune disorders underlying the development and progression of RA. The effects of tofacitinib therapy on central sensitization confirms the presence of specific effects in JAK inhibitors affecting the development of chronic pain. Thank you so much for your attention. I hope it will be interesting.
Hello, I'm Laure Gossec, a rheumatologist from Paris, France. And it's a pleasure to present to you our work on the association between improvements in patient-reported outcomes and improvements in disease activity in patients with psoriatic arthritis treated with upadacitinib or adalimumab from a phase 3 trial. So we know that the objective of treatment in psoriatic arthritis is to achieve disease control defined by remission or low disease activity. But it's also important to improve patient-reported outcomes, since these are indicators of treatment effectiveness assessed by the patient. Our objective in this work was to examine the association between the improvements in patient-reported outcomes and achieving disease control assessed by stringent measures of disease control, such as remission or low disease activity in patients with psoriatic arthritis. We performed a post-hoc analysis of a phase 3 randomized controlled trial, which is the SELECT-1 PSA study, where patients received either upadacitinib 15 or 30 milligrams or adalimumab versus placebo, and we assessed results at 24 weeks. We defined stringent disease control as achieving remission or low disease activity, measured by either MDA for low disease activity, DAPSA remission, or PASDAS remission for remission, and finally a measure of important improvement, which is the ACR 70 response. And we cross-tabulated these measures of disease control with achieving improvements or good status in terms of patient-reported outcomes. And the main patient-reported outcomes we explored were FACIT for fatigue, SF-36 physical and mental components for general health-related quality of life, and also the WPAI for impairment or improvement in terms of work outcomes. So we were able to analyze more than 1,700 patients. We pooled patients from the active treatment groups and the placebo groups. And these patients had a mean of 6 years of disease duration, and they had quite high disease activity at baseline with a mean swollen joint count of 11 and tender joint count of 20. The first result is that overall, we found the proportion of patients who achieved clinical measures of stringent disease control were more important for low disease activity, here MDA, reached in 32% of patients, than remission, reached in 10 to 13% of patients, whereas ACR 70 was reached in the middle category of 23% of patients. Then we explored if patients who were improved above minimal clinically important difference for the different patient-reported outcomes were also reaching stringent disease control. Firstly, we found that for MDA, patients who achieve improvement above MCID are indeed reaching more often MDA. And in this case, we found that around 40% of patients were reaching improvement above MCID for the patient-reported outcomes, and that among these patients, up to half of them were reaching MDA. And for patients who reached a normative value of fatigue or a normative value of quality of life assessed by SF-36, it was up to 75% of these patients who would reach stringent disease control defined by low disease activity, so MDA. Among patients who do not improve in terms of their patient-reported outcomes, it's interesting to note that around 20% of them do still reach MDA, so low disease activity. When we look more specifically now at remission outcomes, we find again a strong link between reaching improvement in patient-reported outcomes and reaching remission. But because it's much more difficult to reach remission, patients who improve in terms of their patient-reported outcomes, only 15 to 20% of them are reaching remission status. But among patients who do not improve for their patient-reported outcomes, only 2 to 8% of them do reach remission status. So it's very difficult to reach remission if you're not improving in terms of patient-reported outcomes. And for ACR 70, the results were a little bit in the middle, with around 30 to 40% reaching ACR 70 if they did reach improvement in their patient-reported outcomes. So to conclude, dear colleagues, we found that patients who reported clinically meaningful improvements, or even more so, normative value for key patient-reported outcomes, were more likely to achieve stringent measures of disease control. Reaching MDA or ACR 70 response was much easier, and therefore was found in around 50% of patients who reached improvement in their patient-reported outcomes, whereas reaching remission is much more difficult. And therefore, even among patients who do improve for patient-reported outcomes, we observed only 15 to 35% of remission. These results demonstrate an association between improvement in patient-reported outcomes and achievement of stringent disease control, which may suggest that patient-reported outcomes are a way to assess treatment efficacy when treating with upadacitinib or a TNF inhibitor in psoriatic arthritis. Have a lovely Congress.
Hello, my name is Anthony Seba. I am a rheumatologist in clinical practice and assistant clinical professor at the University of South Florida in Tampa, Florida. I'm a co-author on the abstract headed Pain in Patients with Rheumatoid Arthritis Who Did or Did Not Achieve Treatment Response Based on Improvement in Swollen Joints with Baricitinib Clinical Trials. I wanted to preface this by discussing the genesis of this. There's been increasing data accumulating that in rheumatoid arthritis, the joint inflammatory process is not solely responsible for the pain that's felt by patients with RA. We've all seen patients who present with pain in the MCPs, PIPs, wrists and shoulders, and often these are women in their 20s through the 50s, the right demographic for rheumatoid. And we're hesitant to call this rheumatoid because they have no signs of inflammation, they only have pain. The obverse of this is patients who come with big swollen joints with sometimes with erosions and no pain whatsoever. These patients are regarded as robust rheumatoid, and these just both seem to illustrate the notion that pain can be disconnected from inflammation. So to further explore that, we looked at an analysis of the so-called RA BEAM study, which was a baricitinib study from several years ago. Now, baricitinib is a JAK, a selective JAK inhibitor, JAK1/2, and the study had about roughly 1,200 patients. There were 3 arms, and those are in the bottom left of this poster. There was placebo for 24 weeks, and then baricitinib 4 milligrams. I need to emphasize this dose for US listeners, where the standard dose is 2 milligrams, and ADA. ADA was given at 40 milligrams every couple of weeks in the approved dose. Now, the primary endpoint of the study was to explore the relationships of these 3 arms. We're interested in looking mainly at BARA and ADA with respect to pain and swelling. Now, we chose swelling because there's no other obvious metric of inflammation that we could use. We're using BARI, which does affect IL-6, and IL-6 drives CRP and sed rate down in virtually everybody. If we looked at patient global assessment, that's driven by pain, and physician global assessment is largely influenced by patient global assessment. So the most independent metric we could find of inflammation was joint swelling. And we will be interested in what happens if we compare patients who did have reduction in joint swelling and those who didn't. So the first thing I should comment on is that the overwhelming majority of patients in both ADA and BARI did in fact get a 50% reduction in joint swelling. Now let's look at the line graph, the first line graph on the left. That's patients who did get a 50% improvement in swollen joint count at week 12. And you can see that, just stepping back for a moment to the broadest terms, you can see that both ADA and BARI are differentiated from placebo at 12 weeks. And you can also see, if you look at BARI in the next figure, the next line graph, even in patients who didn't improve at 50% joint swelling, there was still a reduction in pain. So BARI seems to reduce pain whether or not there's pain, swelling reduction. However, the magnitude of the pain reduction is perhaps somewhat better, somewhat greater, or appears greater in the group that had a 50% improvement in swollen joint count. Now, that's not true with ADA. ADA has quite a nice reduction if you get a 50% reduction in swollen joint count. But in the patients who did not have a swollen joint count reduction of 50% at week 12, ADA did not appear to make a big difference. There's a statistically significant difference between pain reduction in patients who did not have an improvement in joint swelling between Barry and ADA. And you'll see the same thing at 24 weeks. They're generally similar in terms of the magnitude, in terms of the 12-week results and the 24-week results. And again, at 24 weeks, there's a significant difference favoring Barry between Barry and ADA in terms of pain reduction among patients who do not appear to have a 50% reduction in swollen joint count. In order to try and clarify this further, we did look at the swollen joint count 20% threshold. That's in the bottom right. And once again, you see that ADA and Barry are somewhat similar in the patients who had an improvement in 20% swollen joints. But again, if you look at the swollen joint count among those who did not have an improvement, that's at the right-hand graphic, there's a very substantial statistical difference between Barry and ADA. Now, the reason this wasn't the primary endpoint of this retrospective analysis is the numbers are very small. As you can see, there's 40, 50, something like that in these arms. So it's obviously 20% of 1,200. So the numbers are much smaller, and the statisticians felt that this was less reliable. So the main emphasis here is on the 50%, but it's interesting to know that even among those with a 20% non-reduction in pain, there's a difference between Barry and ADA. So to summarize, the 2 points that I wanted to emphasize are that there does appear to be a mechanistic differential effect in reducing pain between those patients who do have reduction in inflammation and those who don't. There may well be some medications that focus much more on reducing the pain, and we've all seen patients who seem to respond very, very well with inflammation, but still continue to have pain. That may be a function of the medication that we choose. We don't know enough to inform this decision, but it's interesting to know that there do appear to be differences in medicines that work similarly for inflammation. And I would encourage everybody to start measuring pain as an independent variable early on and follow pain as a metric. Thank you.
Thanks for joining us for this edition of ACR Highlights. I hope you enjoyed these presentations. Make sure to subscribe to CSF podcasts on Apple, SoundCloud, or wherever you get your podcasts so you don't miss out on Congress content or any of our other usual monthly presentations. You can also visit CSF webpage at cytokinesignaling.com, where you can access a whole range of resources, from the monthly slide summaries of latest papers to accredited CME courses and even more. Thanks for listening.